when do you select inotuzumab, blinatumomab, or CAR T cell for a patient with relapsed refractory B-ALL? So this kind of question is very frequently addressed currently during all the ALL meeting, because we do have several drugs recently approved to treat relapsed refractory patients. And obviously people are wondering which is the best, which drug should come first, and the other after, another and other. So maybe I can just try to guide the discussion by asking you some more specific question on that point. So the first question would be, do you think there is a need, an absolute need, to control the target expression when using such an immunotherapy or antibody-based therapy when you treat relapsed refractory patient? I mean, to control the expression of the target at the time of relapse, at the time you will initiate the therapy. So it will be my first more specific question on that topic. So maybe who want to comment?
Hervé, do you mean, I'm trying to understand the question. Do you mean in terms of controlling the antigen expression, do you mean whether you consider the level of antigen expression as you choose the treatment? Is that
exactly? Exactly.
Yeah, I do think that that's an
or what level of non-expressing cells you would recommend not to use the drug.
Right. And also perhaps biological subset, you know, for example, the mixed lineage leukemias, etc.
For instance,
Hervé, these are Elias Jabbour, but these are questions for us. We all work in academic sites and we have our clinical trials that we all will favor. So the debate is more for the community setting where people are not so clear on what to choose. But for us, as for everybody here, we have our clinical trials and we try to enroll patients into the trials.
Obviously, but we are who we are today. We cannot speak for the other, but let's just comment on what is your current practice when you have a relapsed refractory patient. I guess there is a lot of criteria guiding you to use either blina or ino or CAR T cell directly. But among these criteria, do you, I guess you do that, but do you control the level of expression of your antigen at the time you initiate the therapy?
Got it.
Go ahead, André.
Oh, please, ladies first.
Well, I would say that, yes, I do consider that, and that, you know, from the data that exist, you know, if you're thinking about relapse treatment, relapse disease, if, you know, it appears, at least from the literature, that, you know, it doesn't really matter the level of expression of CD22 when you're dealing with inotuzumab. It seems to work well when there's both relatively low or high expression levels, whereas potentially with blinatumomab, and I don't know about CAR T cell, but that's a more important consideration. And then, of course, the worry for me in the very rare subset of the mixed lineage patients is any of these targeting approaches is a bit risky in the sense that you could end up with a myeloid leukemia when you target. But for overall, I would say that if there's low expression, antigen level expression of both CD19 and CD22, I would opt for inotuzumab over blinatumomab simply because the data seem to support that better. I don't know what other people think. And that's just the beginning of a discussion, I'm sure.
Thank you, Wendy. Other opinion on that point or larger point, if you want?
To your question, do we test? The answer is yes. To the question, is it easy to test? The answer is no, because the number of cells expressing the target is generally the answer given by the flow cytometry. But if you want to know the density or the mean fluorescence intensity, then you run with a much more difficult information that you ask to the lab. And thirdly, the difficult information, particularly in the CAR T cell field, is there a subpopulation not expressing at all the target? which exist. And we have seen, and it is, for example, in one clinical trial with the Kite drug, they asked for at least to be included, you do not have to have more than 10% CD19 negative cells. So these are the kind of things which can happen. And also I would add on what Wendy says, is that we know that sub-entities like, for example, MLL leukemias do not express so much CD22 and sometimes do not express at all CD22. So particularly depending on genomics, you have also to refine this information of is the target present or not. I will stop here.
Thank you very much, André. Other opinion or intervention or comment on that point? Sorry, Sabina?
I'll do test it.
Okay. Okay, so I have a second specific question on this topic. You have a patient with a relapse B-cell precursor ALL, and you have a donor, an allogenic donor to transplant this patient. So he's well, he can tolerate transplantation, he has not been transplanted, he or she has not been transplanted before, and so you can use stem cell transplantation. So with that in your hands, would this information influence your choice to treat the patient prior to go to transplantation first, or to treat the patient not with the transplant and not with the donor you have, but with one of these new options? So I'm saying that I can explain myself maybe a bit more. You have a donor to do transplantation. So usually we are considering liver toxicity with inotuzumab when you are applying a transplantation after treatment. Second, usually, at least in my mind, CAR T cell might be an alternative to allo transplant. So why to use CAR T cell if you want to go to transplant? So maybe blinatumomab would be the choice, the natural choice, if you want to bridge your patient to allo transplant in second remission.
Well, the question is, do we need a transplant with CAR T? Can CAR T be standalone finite therapy, especially in a multiple relapse patient? What do we know about transplant? How much it helps?
I was waiting your comment on that, Elias, specifically.
So first, Hervé, you should define if it's first relapse or not.
Yeah, first
Are
relapse.
you talking about first relapse?
First relapse, but I'm an adult hematologist, probably for.
Okay, so first relapse, I'm not sure that any CAR T commercialized is approved for first relapse without being refractory.
Actually,
right or wrong?
No, the studies were like that, absolutely, Andre. But in the United States, anyway, the approval for the CAR T product for BALL is allowed for first relapse. The indication doesn't suggest or doesn't mandate relapse refractory.
Okay.
But it's a very good question, and there's not a lot of data on that in terms of.
You are referring to Tecartus, I probably.
Yes.
Yes.
Correct.
And Tecartus is a non-persisting CAR T, at least at the first glance. Okay.
Correct.
So Hervé, are we discussing only our decisions within the framework of approvals, or of what we think is we should be doing? And in that regard, relapse refractory, it's not only first or subsequent relapse. I would include the molecular, which for me is relapse if there's recurrence at the molecular level. And I think that might have a different decision. On if we are looking at overt relapse, I've not been convinced of either of these to be sufficiently effective to warrant eliminating allotransplant as the principal option. maybe using one of these as the bridge. But then going to transplant, that would be my default still. I might be old fashioned. With the molecular relapse, I think we could have a different discussion.
I agree with Oliver. I think the pediatricians, I could look it up. I think the pediatricians have presented some data that transplant is superior to CAR T. This is retrospective data, but so I would favor transplant over CAR T as say destination therapy, so to speak. Typically, I would use blinatumomab as a bridge to get them into remission and hopefully MRD negative, and then going to transplant. Some of the reasons people have mentioned.
I also agree that I don't think yet that there's sufficient data for just using CAR T alone as a relapse strategy. There are patients who do have long-term remissions, at least short long-term remissions anyway from the published data, but I don't think we have a product yet that would overcome my inclination to use transplant, even if you use CAR T as a bridge to it. The one exception, I guess, that I would say, and this is not the situation that we're talking about, is after an allo transplant, if people relapse, then I have considered using CAR T as a sole therapy to try to restore donor chimerism and not necessarily go forward with another transplant. But the number of patients where that's been done for me is very limited. So I really can't say anything definitively whether that's an appropriate approach.
Okay, thank you, all of us. I will continue with some question on that topic. Maybe stupid question, but okay, it's here to launch a discussion. So my further question will be on combination. So I'm talking here mainly for inotuzumab and blinatumomab, not CAR T cell, because I'm not aware of many combined treatment with CAR T cell at the present time. But with Ino and Blina, when you have a patient with a relapse disease and the drug are approved as single agent to treat patient with relapse ALL, are you inclined to combine this compound as we are doing in frontline treatment, actually, for instance, in elderly patient with Ino, or even in younger patient with Blina currently? So do you prefer to use Ino or Blina combined to other things, even in relapse refractory patient or not?
Combined with what else? Are you combining Ino and Blina, or combining?
No, combining Ino with chemo or Blina with chemo, yeah.
It's being done, correct?
Yeah, it's being done frontline.
So if we done worldwide, we did the immunogenicity Ino, but people are using different combination, and I know Blina are being combined together as well. The alliance at MD Anderson and elsewhere, and we're giving Blina sequential, and today in the USA, it's part of NCCN recommendation to give a Blina as a consolidation.
I agree, Elias, but these drugs are not approved like that at the present
Correct.
time. So,
Correct.
So
you're right.
That's why I asked the question.
Correct.
Maybe to push the company to try to approve the drug in combination as well.
But are you talking about sequentially, or are you talking about, you're not talking about combining these with chemo at the same time?
I would say both. I mean, well, because we are investigating combination in frontline patient. Elias mentioned the IPC Ino study. We did the same in Europe with the so-called EWAL-Ino study.
Correct.
But yours was sequential, wasn't it, Eli?
Yeah, with Ino, it's more sequential with Ino than with Blina, obviously.
We did combination, concomitant combination, Mark, with Ino.
Yeah.
And a Blina sequential.
Could we consider, Hervé, to answer your question, that Ino is essentially a targeted chemotherapy, and Blina is essentially an immunotherapy, which depends on the fitness of T cells. So to use them concurrently is not logical because with INO, you damage your T cells. So what I would take your question as combining INO as MD Anderson and others have done with chemo is probably a feasible option. But combining blina with something else is not easy because the something else is likely to destroy the T cells. So that's my point, that if we're talking about blina is per se a drug, which means you have to use it in a window, not concurrently with some toxic chemotherapy. It's just a way to orientate the discussion, my comment.
Thank you. Thank you very much, André. Other comment on this use of INO or blina in the relapse setting? What would you like to do?
I think what everybody has said is something that we are, many places are exploring right now without chemotherapy is INO followed by blina and then transplant. That seems to be a logical approach that has already been tested and is being tested right now, as Ellie mentioned, in the Alliance in the relapse setting. And it makes sense because that gives you some bridging to get rid of potential minimal residual disease and allow some time between the inotuzumab and the exposure to transplant. So, to avoid hopefully the toxicity.
The next pediatric European protocol will randomize INO alone versus intensive chemotherapy called UCALR3, and then go to blina and transplant. So probably in the same way.
Okay, so let's say that's not totally clear, but we have some indication on how to use this drug or how you want to use this drug or how you are using this drug for relapse refractory patient. So the second question, we addressed that issue with the others. So can CAR T-cell therapy replace allo treatment? So my only, let's say, and maybe last question on that is, and probably you will comment on the persistence of CAR T-cell. So is the persistence of CAR T-cell, the different CAR T-cell products, absolutely crucial to renounce or to not use allogenic stem cell transplantation after CAR T-cell?
Maybe I can begin.
Yeah.
What we have shown, and many others, and all the group of people doing CAR T-cell in bilineage GLL in infants, children, adolescents, and young adults, that persistence seems key. Obviously, there are some outlier papers. I will discuss that afterward. What we consider at the moment as indication of transplant after CAR T cells are the patients, first, who are not in molecular CR at day 28, second, who lose early the CAR T cell, which means they lose B cell aplasia within the first 6 months. These patients are, I would say, there is a kind of consensus about the need for going to transplant for these ones. After 12 months of persistence, everybody is on the wait and see attitude. Between 6 months and 12 months of persistence, there are discussions depending on cases. So this is just to set up the scene at the moment. Tecartus paper is a problem because some of the patients in the Tecartus paper in Lancet have not been transplanted and are doing well, but the follow-up was still extremely short because the pediatric experience followed with mixed by some adults at NCI by Niralisha, all the CD28 CAR not transplanted patients finally relapsed. So I would say that I consider the Tecartus paper as an outlier one at the moment, but maybe I'm wrong in the next future.
Thank you, André. Very clear and with some very precise time points, 6, 12 months. So does it mean, André, that after 12 months of persistence of CAR-T, it's time to eliminate the CAR-T by some suicide gene or something like that?
Problem is that there is no black and white answer, since, for example, our last relapse was a patient who lost the CAR at 12 months and relapsed 2 months after. So after 1 year, it's clear that the longer the persistence, the higher the probability of cure or the incidence of CD19 negative relapse.
Okay, so it's not prime time for
Your question is very difficult. Even if I have a suicide gene today in my CAR, I don't know when to activate it.
Okay, other comment on that point?
Just maybe.
Yeah. No, go ahead, Oliver.
Yeah, if we look at the relapses after transplant, I mean, clearly there are quite a few after the first year. And so assuming that there is some immunological effect essentially responsible for the transplant effect, I would think that terminating any immunological activity as early as 1 year would be premature, just conceptually.
Okay, thank you.